everyone. Thank you so much for joining the Maine Health Management Coalition today. My name is Marie Stuckey. I'm the Member Relations Specialist here, and I'm very pleased to present you with a webinar on shared decision making in primary care, barriers, remedies, and implementation. So as we begin, I just want to give you a little bit of information about the coalition for anybody who's listening who is not currently a member. And also we'll also begin by explaining to you that at the end of the presentation by our two presenters today, we do have a time for questions and answers. So you will be muted during the entirety of the presentation, but please do feel free, and you are encouraged to type questions in the chat box, and we will read them to the presenters at the end of the broadcast of their presentation. We will also have this presentation recorded and the slides available on our website for later reference. So the Maine Health Management Coalition is a purchaser-led partnership among multiple stakeholders working collaboratively to improve health and maximize the value of health care for all the employees and dependents of the coalition members and residents of the state of Maine. We have several different membership categories, including consumer groups, employer purchasers, health plans, broker, benefit consultants, providers, and affiliates. And basically our vision is to lead the country in population health status, and patient care experience, and low per capita health care expenditures, so that we have a favorable economic climate here. The way we accomplish this is through 5 key initiatives. The first one that you see there at the bottom of your screen is through our data department. It's basically the foundation for all the improvement in the state of Maine, because we have the state's all-payer claims database, which gives us very good information on healthcare spend. We also do public reporting on provider quality through our Get Better Maine website. We provide consumer engagement through a variety of means, such as book clubs, competitive wellness programs, and other wellness initiatives. We also are very active in the area of benefit design, working directly with the major health plans in the state to develop a new health plan called Value-Based Insurance Design. And today's presentation on shared decision making is particularly applicable to our Value-Based Insurance Design initiatives, because shared decision making is incorporated into that plan. If you'd like to learn more about the Value-Based Insurance Design initiative, you can go to our website, and at the top of the menu you can find information under Employers VBID, or go to Member Resources, Archived Webinars and Presentations, and if you scroll down to VBID 101, you'll see a presentation from March 18th with video and slides that will give you an overview on that initiative that we work on. And finally, we work on payment reform, working with providers and hospital systems in the state to keep costs down for healthcare here. So I wanted to alert you that we have another webcast coming up just a week from today on specialty pharmacy, understanding the business model and why it's important, and that is going to be presented by Navitus. If you would like alerts to know about all the webinars we have coming up, you can sign up for those right on our homepage. And we do sometimes offer credits for some of these educational webinars, and they are free to our members. Non-members do pay a fee for our webinars. Our members also enjoy other opportunities for involvement through networking and voting rights on some of our work groups and committees for making change here in the state. We offer broker and member newsletters, training on our value-based insurance design, and training for evidence-based medical policy for legislators. One date you're going to want to keep in mind and mark on your calendars is the 18th of November. we will be having our annual symposium, and we're very excited about this. We've got a great keynote speaker, and it's going to be a wonderful, informative day of education and networking. It's the theme of the symposium is Leading Change, How to Make Switch from Volume to Value. So we hope you can make it and join us. Here is a list of our current members, and you can also find this on our website. And I'm going to go ahead now and introduce our first speaker, Dr. Mark Friedberg. He's a senior natural scientist at the RAND Corporation, practice lead in payment models and healthcare delivery for RAND Healthcare Advisory Services, and a practicing general internist. His research focuses on performance improvement by healthcare providers, innovations in primary care, and methods for measuring health system quality and efficiency. Dr. Friedberg has developed and fielded surveys of patients, physicians, medical group leaders, and other clinical staff. His clinical work has included ambulatory primary care and hospital-based internal medicine, and he is an assistant professor of medicine part-time at Brigham and Women's Hospital and Harvard Medical School. Dr. Friedberg received his BA in Economics and Statistics from Swarthmore College, his MD from Harvard Medical School, and his MPP in Healthcare Policy from Harvard Kennedy School of Government. And with that, we're going to switch the presentation over to Dr. Friedberg, and thank you so much for your time today.
Thank you very much for that introduction, and thanks everybody on the phone for attending today's talk. It's a real honor to be able to address you and tell you a little bit about the research we've done on shared decision making in primary care. I also want to just thank my co-authors on this research project that we completed a couple of years ago, Kristen Van Bussum and Eric Schneider. So we evaluated a demonstration of shared decision making that was conducted by the Foundation for Informed Medical Decision Making. And this demonstration included 8 primary care sites. These were large sites that actually had multiple clinics within them. So they included about 34 primary care clinics total. And these sites were selected for their prior experience doing quality improvement initiatives. Some had previous experience doing shared decision making, and specifically with decision aids, but some did not, and were chosen specifically because they would be new to this kind of this aspect of quality improvement in primary care. The demonstration was conducted between July 2009 and June 2012. As I mentioned, it was sponsored by the Informed Medical Decisions Foundation, which is now, I believe, part of a different company. And it included free decision aids as one of the key inputs to the primary care practices that participated, as well as technical assistance and participation in a learning collaborative that included all of the primary care clinics. We performed a qualitative evaluation of this demonstration about halfway through, at about the 18-month mark. And the intent of the evaluation is as follows. First, we sought to identify barriers and facilitators to implementing shared decision-making in primary care settings. And second, to develop options for evaluation and measurement of shared decision-making performance in the primary care setting. To do this evaluation, we performed semi-structured interviews. We did this with 23 leaders and clinicians from all demonstration sites, as well as 10 patients from one site who had each received a decision aid during the demonstration. Our protocol investigated facilitators and barriers to engaging clinicians and integrating decision aids into key operational tasks of shared decision making. We analyzed interview responses inductively to look for recurrent themes, and that's what I'm going to be presenting today. So first, one of the products of our project was a diagram, sort of a conceptual flow of the key steps of shared decision making based on decision aids. And I should say a word about what decision aids are for those who may be unfamiliar with them. Decision aids are materials generally in the form of a booklet or a video that are given to patients, and people sort of call them prescription strength medical information. And they're designed to be understandable to patients, so you don't necessarily have to have any kind of healthcare training or background to get the information in them, and they are very carefully constructed to make sure they're as understandable as possible, even though they sometimes deal with some complex issues like risk trade-offs and uncertain futures with different medical decisions. But before you can distribute one of these, starting on the left end of the diagram, first there's the task of identifying a decision opportunity. This is a situation where a patient faces an opportunity. Maybe they just turned 50 and they haven't been screened for colorectal cancer, and now there's an opportunity to talk about the various ways they may wish to be screened for that condition. If there's a decision aid matched to that opportunity, it needs to be selected. Then there's the step of decision aid use. This is the decision aid being distributed to the patient, and of course the patient using the decision aid. And this can happen at home. This can happen in the office. Some clinics are set up with a special space where patients can view the decision aid. And after that's done, there should be a post-decision aid conversation with a healthcare provider. It doesn't have to be the PCP, him or herself. It could be another healthcare provider. And the purpose of this conversation is to clarify the medical information in the decision aid, to make sure the patient understood everything that was in there, and to answer any additional questions the patient may have, to elicit the patient's values and preferences. This is really the task of the patient now educating the physician or whoever this person is who's having this conversation with them about the things in which the patient is the unquestionable expert, which is his or her own values and preferences. And then together, the provider and the patient make a shared decision that is the subject of the decision aid. And then, of course, the fourth step is the delivery of health care. And once a shared decision has been made, ideally the care that is delivered is actually consistent with that final shared decision. And this isn't to say that these steps need to occur in exactly this order, and that once you complete one step, you have to move on to the next. It's certainly the case that decisions can be reconsidered over time before the final delivery of healthcare, or in situations where healthcare delivery is not a one-time event, but is a repeated event. So first I'm going to talk a little bit about some barriers to shared decision-making in the primary care setting that we uncovered. First was that overworked physicians did not recognize decision opportunities and distribute decision aids reliably in the primary care setting. Site leaders who relied on physicians to trigger the distribution of decision aids, they didn't really know, but they sort of estimated that around 10 to 30% of patients facing decision opportunities received the aids. And this was pretty much corroborated by the physicians themselves. So here are a few illustrative quotes. The first from a site leader. As long as you have the physicians in the middle of distributing decision aids, they have too many other things on their plate to reliably ensure that this would happen every time in a 10 to 15-minute appointment. Another site leader said, we hear physicians say, I seem to be the problem here. How do I get myself out of the loop so we can get the decision aids to the people that need to get them? And in the real world, I'm not sure we can expect physicians to identify the patients. The next barrier that was commonly reported was insufficient provider training. Recognizing decision opportunities and having post-decision aid conversations are skills providers must learn. They're not necessarily covered in traditional medical education in any depth, and so the sites recognized that this was something that in order to do the full process of shared decision making well, the training was in a lot of cases going to happen right there in the site. So here's an illustrative quote, again from a site leader. We found that physicians felt they were already doing shared decision making before we introduced the decision aids. To me, it's not really shared decision making when there's only a 15-minute appointment and patients can't really engage in a conversation when they don't know much about the topic. Another site leader said, you really have to pay attention to the clinicians in this equation. You can't just ask them to do something and assume that they'll know what you mean. We underattended the training of our clinicians. Finally, the most common barrier we heard about was inadequate clinical information systems. As I'm sure you're all acutely aware, there's been a big push to get clinical information systems, and especially electronic health records, into primary care practices as well as other kinds of physician practices. And all of these sites did have an EHR, problem was that they weren't able to do some important things with it that would have facilitated shared decision-making. And in particular, they were not able to track the full sequence of steps involved in shared decision-making for a given patient. So for example, they were unable to flag patients as candidates for decision aids or indicate which patients had received them with the EHRs they currently had. They lacked mechanisms for communicating patient-reported values and preferences to providers in a way that the providers would then see at that post-decision aid visit. And there were no longitudinal functions to track patients through the shared decision-making process, including determining whether patients had a timely post-decision aid conversation with their providers. And of course, thereafter, whether the care was delivered that was consistent with that decision. They were also not able to integrate with the decision aids. Some of these decision aids included a questionnaire that the patient would complete on his or her own. This was generally a paper questionnaire, and it would be sent back to the practice. The problem was there wasn't a way to get that information back into the EHR so that the provider could see it. So there was a little bit of a lost opportunity there to communicate the values and preferences back to the physician or other provider. A good example was here. All of the information in the decision aid questionnaires is off the chart. There was documentation in this particular system that a decision aid was given, but anything from the surveys was kept completely separate. So now I'm going to focus a little bit on some solutions that sites employed to some of these problems. The first really triggered that problem of the physicians not being able to distribute the decision aids reliably. Here, a site, and several sites actually did this, they had automatic triggers for decision aid distribution. For example, they would trigger on patient age and gender for screening, and this seemed to be most applicable to screening decisions. So here's a site leader describing how they did it. The more automatic you can make it, the more successful decision aids can be in primary care, whether that's having the health technician prescribe it or having it be an automatic mailing based on visit type. Anything you can do to streamline the process and not rely on clinicians' memory to include the decision aid as part of a visit routine will be a successful strategy. Another way of triggering it was to tie the distribution of decision aids to specialist referrals. And this was particularly the case for surgical procedures. The one benefit of this was that the relative greater focus of specialist visits on really one problem at a time in most cases when it's a surgical procedure under consideration was thought to facilitate more reliable performance of a post-decision aid conversation. So another site leader described that in the specialty clinic, the decision aids are much more frequently discussed. It is a bigger challenge for the primary care practice because there may be several things a patient wants to discuss, but when you see a specialist, you see the doctor for a particular purpose. Another solution to this problem was to engage team members other than physicians. So for example, a decision coach who was there really in a dedicated role surrounding shared decision making might introduce the decision aid to the patient. There's a patient describing when you're with the doctor, you don't get a chance to ask a lot of questions. A nurse I had never met before came in and introduced me to the decision aid. She had a CD and a book about the surgery, and of course I was interested in that. Now I'm going to shift gears a little bit and talk about knowing whether a given effort to try to introduce shared decision making in a primary care setting, whether we know it's successful. So this is all about measurement. One implication of that flow diagram I showed earlier with the 4 boxes is that process measures really should capture all steps of shared decision making if the goal is to get all the way from a decision opportunity to care that is consistent with a shared decision. And that means that all or none measures may be appropriate. And to illustrate this, it's important to remember that even if a decision aid is prescribed and used, poor performance of the post-decision aid conversation can completely undermine the whole effort. And there was a sobering story about this by Lynn and colleagues in Archives of Internal Medicine in 2012. I highly recommend it. It's a quick letter and really illustrates the problem that if a decision aid is distributed and the patient uses it and comes to a really good understanding of what might be most consistent with his or her values, if the clinician is then not able to incorporate that into the kind of screening that might happen, the patient may choose to forego it completely, even though they actually would like to have one form of screening that this particular physician didn't want the patient to have. And just to illustrate the point, there may be some vulnerability in later steps of shared decision making, even if the first couple of steps can be addressed, which is where most of the action was in the demonstration we evaluated. And these rate limiting steps seem like they're important targets for measurement once those first two steps have some strategies. There's also the approach of measuring decision quality. The idea here is, in the end, was care consistent with the values and preferences of the patient? This can be done through a patient survey, and this is a little bit of this is a difficult methodological area. A lot of folks have worked on this over time. There is some difficulty in the following way. Sometimes after care is delivered, the satisfaction of the patient with his or her decision is dependent on the outcome of that care. And it's important to remember that whether a decision was the right decision might not necessarily mean it was the decision that led to the best outcome. You never can have a guaranteed outcome from any medical decision regarding treatment. And so you know, you might actually have a very good process and still have some bad outcomes just by chance as a necessary consequence of doing medical care over a large number of people. And you know, getting to 100% on these kinds of measures may not be realistic for that reason, although they're certainly worth looking at. There's also the possibility of indirect measures of shared decision-making performance, and these don't involve surveying patients or looking at processes of care. The idea here is that in theory, shared decision-making should produce variability that is driven entirely by patients and not by providers. And the logic there is that the science you know, facing a given type of patient is pretty much the same from patient to patient, you know, allowing for some biological variability between patients based on their age and comorbidities and individual histories. But most of the variation should really be driven by differences in patients' values and preferences, which are likely to vary quite a bit more widely. And this shouldn't be driven by providers' values and preferences. And to give you an example of how this might work, if you look at the providers in your organization, and each of them has a PSA screening rate for men of 100% or 0%, meaning they either do a test on all of their men or none of their men, the organization is unlikely to have implemented shared decision-making for PSA screening successfully. I don't know what the right percentage is, but it's likely to be somewhere between 0 and 100. So there are some implications here of this research. First, achieving shared decision-making will require new operating systems for primary care practices. Sort of an underlying theme of what we heard. By analogy to smartphones, this is a little bit, shared decision-making is not really like installing an app. It's more like really upgrading the entire operating system. This means that there may be some major investments necessary in developing and improving educational operational informatics systems, and payment reform may be a necessary, although not sufficient, condition for helping this work, as long as the main providers in the clinic are continuing to be paid on a sort of a traditional fee-for-service basis. The additional services that are not with the patient face-to-face, in terms of tracking patients over time, may be a net cost to the practice and undermine the sustainability of such efforts to some extent. Sometimes people ask about medical homes and whether shared decision-making seems to be working there, and there's no data yet. Doesn't mean it doesn't work, it just hasn't been studied, on the successfulness of shared decision-making in medical home implementations. There's some reason to think this is going to be difficult. Given all the barriers that we found, you might see this as a quadruple axle of primary care. The ability to do shared decision-making well probably implies that many other capabilities are present and functioning. Given the degree of difficulty, I think it's logical to expect some disappointments as practices figure out how to do this, and we shouldn't be discouraged by those. It's a matter of experimentation right now, and hopefully we can all learn from each other. For sure, watch the measures in this space. Distributing decision aids is not sufficient to guarantee that the rest of the process happens. So if a medical home evaluation reports decision aids being distributed more regularly, that's fantastic. The next question is, okay, well, what can you tell me about the later steps? Finally, there's a key issue for policymakers, especially in light of some of the new payment models that CMS has been encouraging over the past few years, including accountable care organizations, which are actually required to engage in shared decision-making. the key issue is, how high to set the bar for deciding what counts as engagement in shared decision making. A lower bar would be just requiring a count or a certain rate of decision aid distribution, assuming that you can identify folks who should be receiving those. A higher bar would be that all or none process measure, including all steps of shared decision making, or one of those other measures I mentioned, like decision quality, or looking for the absence of clear violations of shared decision making in administrative data. Thank you very much for inviting me to speak. And I know we'll have some time for questions a little bit later, but I think we're going to be turning it over to one of the other speakers now. Thank you.
Dr. Friedberg, thank you so very much. That was wonderful, very much appreciated. And I want to remind everybody to please go right ahead at any point and type questions in the chat box, and we will save them for the end of the presentations. So right now, I would like to go ahead and introduce our next speaker, Dr. Charles Keller. Dr. Keller is a family medicine physician who has practiced medicine for 14 years, most in his home state of Iowa. He currently works both in clinical practice and administratively as the physician lead for primary care at Mercy Clinics. His organization, Mercy Clinics, is a large multi-specialty group with a very large primary care group that has a long history of high-quality medicine with early adoption of health coaches, clinical databases to track patient outcomes, shared decision-making, and early entry and significant success ACO endeavors as a result. Dr. Keller is focused on continuing these efforts to provide high-quality, individualized patient care with utilization of shared decision-making in a variety of areas. And so with that, I am pleased to present to you Dr. Keller.
Hi, this is Dr. Keller. Can people hear me, first of all?
Yes, we can. We hear you, yes.
All right, wonderful. So, and you can see my slides.
I see, I'm not sure we see your slides just yet. Oh, here it comes.
All right, good. So then let's
just
get
make
started.
It into a, yeah, there we go, perfect.
All right, so first of all, I want to thank the main group for inviting me to be a part of this, and I want to thank Dr. Friedberg for his excellent research and work. I think of myself as a simple family practice doctor. I've practiced for 14 years and really try to think of myself and force myself to practice as an engaged physician who is trying to help patients lead themselves towards the best potential outcomes. And let's see if this will now move forward. There we go. Okay, so first of all, just a little bit about Mercy Clinics. We have approximately 59 clinics. We've actually grown tremendously over the last couple of years. We have over 900,000 patient visits per year in an outpatient setting. We are part of Mercy Medical Center, which includes 2 hospitals and also employs quite a few physicians. We're owned by Catholic Health Initiatives, which is based in Denver. We have moved into an ACO model under the guidance of Dr. David Swiskowski over the last few years, and so when you look back 30 years ago to where the clinic started with single outpatient family medicine clinic and how things have grown, it has been tremendous growth, and we now have a very large and fairly successful ACO that encompasses a large part of Iowa. Some physicians are employed as part of our network, some are not. If you can see my pointer, we are here, Mercy Clinics, Des Moines is based here. Mercy Health Network is much broader than this, and the ACO is even broader than that. When you look at the number of lives that we are trying to impact and why this is important to us, you can see that the total number of patients is very large, over 125,000, and continues to grow, including our own employees. The ACO vision, this is just to briefly give you an idea of why we're looking at this. It's not just the shared savings, it's really looking at better health rather than more services, and our health coaches, which is part of what I'm going to focus on today, have been a key to the success in both shared decision making and in the transition to the ACO. When we talk about what the general clinical strategy is, you know, so much of this overlaps with what you're doing in Maine, and some of this is touched on by Dr. Friedberg as well, trying to utilize these IT systems and get them to work together using the Advanced Primary Care Medical Home, which is really a process that has proven to be very valuable, but we're still in the early stages. We're focusing on the highest risk patients as well as focusing on system standardization, and then that clinical integration across the continuum is very, very important, as well as obviously the population-based care. Why is the shared decision making important to Mercy's ACO? Really, it comes down to these sort of basic facts. We feel that fully informed patients are going to choose the best plan for themselves, often for less money, safer and better outcomes, improved satisfaction. We feel that shared decision making is patient-centered, patient-centric, consistent with our values as an organization. And we think it also helps us utilize staff and providers to their highest licensure. And we also think it's going to have a positive return on investment over time. That data is hard to come by. A lot of people have asked me about that. I don't have anything to share, but we are trying to look at that. The office-based health coach system started under Dr. Swiskowski, who started a pilot program in his own clinic over 15 years ago, and now has grown to include health coaches in a variety of settings, at least one in every primary care clinic, including pediatrics, family medicine, internal medicine. They have to be RNs. We want them to have clinical experience. We train them to work at the highest capacity of their licensure and work as part of a team. They get extensive training that was developed here, and we also have transition of care coaches at the hospital, and then what we call health navigators that work more administratively, combing through the data to help identify patients that we can reach in other ways besides directly one-on-one, say as they're overdue for return for hypertension, colonoscopy, those sorts of things. When you look at the essential functions of a office-based health coach, they help oversee the management of patients in the disease registry. They work with the patients and families on self-management and support. And really, they are very well trained in interviewing patients and helping them focus on what their health goals are, and motivational interviewing in particular. They focus on coordination of care across the continuum, and we're working on building teams in the acute or hospital setting, outpatient setting, skilled nursing facilities, as well as home health care and other settings, and coordinating that care. I'll touch on this a little bit later. Looking at some bundled payment and how we can utilize these processes too. They assist with quality improvement and process improvement activities, and they help track and assist with health-related needs of the patients, really looking at what are their barriers to care, which often prevent them from doing what even they know may be right. They provide self-management support to the patients. So really, again, this motivational interviewing, goal setting, action plans, improving medication adherence, providing patient education. They do shared medical appointments with our providers, and they are an integral part of helping us with the shared decision making in a number of arenas. When we started down this project, well before I came to Mercy, and I didn't have this slide on here, but Del Konopka was integral in this, worked with Dr. Wetzler and others on this. Dr. Swiskowski was part of this. We wanted to fully inform our patients about preference-sensitive conditions using these decision aids, evaluate the impact of the decision aids on decision quality, and look at the patient satisfaction with the process. I did get a few questions beforehand, so I think this may help some people understand where we found value. We had multiple decision aids available, but we focused on osteoarthritis of the hip and knee, acute and chronic low back pain, colon cancer screening, as well as 2 different advanced directive programs. We did this for a variety of reasons, but this was really where we started our projects. Many other decision aids were and are available. One of the things I think Dr. Friedberg touched on was the physician involvement in the process, we doctors obviously are very busy. We like to think we're busier than everybody else. And we are a funnel point of decision making for the patients, but we saw that our patients and the site saw that these patients felt it was incredibly important that this information came from the healthcare provider in one way, shape, or form, whether it's an introduction, a direct handoff, or something else. And so I think this really told us the importance of having the provider involved in the process and informing the patient about shared decision aids. When we looked at what a patients prefer as far as how to make decisions on managing their medical conditions, I'll show you a couple of these, but when you look at knee pain and osteoarthritis, you can see in the gray, that is the area where they feel that the physician and the healthcare provider, or sorry, patient and healthcare provider should be making decisions together. And that is the vast majority of patients. And as a physician, seeing that only 1 to 4% think we should be making them is both wonderful and a little bit disheartening. But I think for things like this is why we have shared decision aids. When we talk about diabetes, the numbers were similar or perhaps even a little bit higher. And this looks at a before and after here too. And so the numbers do go up, perhaps not statistically significantly, but they do go up as far as that joint decision making and the importance. So anyhow, Dr. Friedberg did an excellent job of going through this. This was a reminder to me as we looked through ourselves and went through what we're doing. How do we approach it and what do we do? So really, when we talk about what were the barriers that we had, to physician buy-in, we have the same things that you saw from Dr. Friedberg. The idea from physicians and providers especially that patients don't want shared decision making. We're unfamiliar with it. It's not a standard of care. It may undermine our own preferences or income in some areas. It obviously takes some time, and if you're not going to do it directly, you still have to do what's called a handoff. The provider training is a big part of this. As Dr. Friedberg explained, they don't really understand necessarily what is shared decision making, or they say I'm doing this. And we do need some training, formally or informally, and I'll talk about that in a little bit. The facilitators were also touched on somewhat as well, but I think that really it's making a part of the process of training our physicians and other providers and integrating it into the processes in the clinic to make it easier to utilize. There's IT barriers and other barriers as well. What we found helped us was that we had an organizational structure in place that helped us move forward on what we felt were important fronts, okay? So we as an organization set up our goals for the coming year, 1 year, 3 year, 5 years, and we use our executive governance council, a council of clinic directors, quality committee, and other things, and we use those structures that have been successful in the past to present the importance and the value of shared decision making, have them be spokespeople and come on board to help us support this. The other thing we did from the start was the original clinics that were involved volunteered to be pilot sites. So it was people who were interested, and then as we saw feedback on the value of this and the importance of this, other clinics became interested. So it was somewhat organic and not necessarily just all top down. It was a somewhat new scope of work for the coaches and providers. So again, we wanted to make sure we aligned that within the advanced primary care model and the ACO vision, which is why we chose some of these things like colonoscopies, osteoarthritis, where patients may be getting inappropriate knee replacements, advanced directives. And then again, we use the same strategies we previously used to look at our chronic care models and utilize those. So again, senior management using the PDSA cycles within the clinics, having physician champions that I'll touch on in a little bit, having monthly team meetings and outcome data review as well, and other things that were already in place. Our philosophy was, as you can see, it takes a proactive, prepared team to provide high quality care shared decision-making is part of that, and we really tried to identify who are the key members in each clinic and at each level that are going to work on this. And we started with the pilot approach. So being a doctor, I think we're important. We identified physician champions. They volunteered. They did not get specific pay for this, but we introduced this idea to them. We got them some training, and then we had them do these PDSA cycles, work with our process improvement teams and other things, and then bring that information forward to other groups through our clinic directors meetings and so forth. They provided forums of communication to the other providers in the clinics, and then also help spread things out outside of this. And I can give you some examples of that later. When we, as we heard earlier, these facilitators to implementation include engaging non-physicians. And so while we felt it was very important to have the physicians or providers involved, we wanted to utilize the other staff within there too and identify the touch points, whether it's through pre-visit chart reviews, looking at the data that we have on our patients, our referral processes and so forth, to try and figure out how we can automate some of this. So if we have somebody going off to orthopedics for chronic knee pain, it may be our referral person who's checking to make sure that they got a shared decision aid if it's appropriate. Part of what we did was utilize our health coaches for pre-visit chart reviews. We did some shared medical appointments, and again, we engaged all our different staff to try and make this work, as many touch points as were appropriate and possible. The health coaches really have done a phenomenal job. They don't do much in the way of pre-visit chart reviews right now, but they started out doing a lot of this, and we're trying to implement this in other ways to identify how we can use shared decision-making in the appropriate places, not just for what we stated above, but also looking at Medicare coverage for lung cancer screening and so forth. We do feel, and again, we don't have great data on this, but that this can be profitable as we go forward. We think that the redistribution of the physician work is going to be helpful. Standardization obviously helps, and we think we get an appropriate increase of volume in medically necessary services, so that we're getting patients back in for diabetes when they're supposed to, getting them set up for colonoscopy when they're supposed to, and things that are actually appropriate that overall are going to increase revenue, especially since we're in that transition between value-based and more direct payment fee-for-service right now. What we looked at as far as shared decision aids to use, initially we looked at what we wanted to for a variety of reasons. What I'd say for you, look at your clinic, look at your patients, okay, and your population, and really think about what would be most useful to you. As Dr. Friedberg touched on, there's a variety of different sources, some of which are written, some of which are online visible, and I'll touch on some of that later. We used some from the foundation, which is, now I've forgotten the name of the group that they're a part of. I want to say it's, I won't say it because I'll probably get it wrong, but anyway, we had both written and DVD information that they could review. For patients with low literacy skills, and I have a few examples of this, the reading in some patients actually may have been too difficult, even though it's at a very basic level, but the visual part where they could watch presentations that walk them through this became very valuable, and there are some online resources for this. When you start to look at how do you start on this, I think you look at where you feel your greatest impact may be and pick something that you feel is doable. We did find some difficulties with when you look at appropriate identification of shared decision aids at the right time, which is always critical. Things like osteoarthritis of the knee and hip were very valuable if we got them to patients early, but once they got on to orthopedics, often they started making their decisions, and giving them the shared decision aid at that point didn't really help them much and didn't impact their decisions as they may have if we'd gotten them earlier. So I think that we really had to try and identify ways earlier in the process, and that's always been a difficult thing for us, but we're trying to find better ways to do that. So as I said, focus on a few key areas, find what's important to your practice, identify some key personnel both higher level and frontline. Start very small and get the support of what you have in the system already in place, whatever that is. You already have tried to do things to improve things in your clinics or on a system level. Utilize those same systems if they've been successful. There's quite a few resources out there that I would encourage you to go look at, and this is certainly not all of them. Some of them are free, some of them you have to pay for, but they have videos on some of these. They have toolkits that you can use. They have ways to approach this, some of which require a lot of input from you or the patient, some of which are fairly basic and you can go on and use. I have found myself using a variety of them, either to educate physicians and staff or to get shared decision aids out to the patients as well. I would say we personally believe this shared decision making is a very important and key component to our future here in patient-centered care, and we are moving forward as using this as well. I would say also, if you want to get in touch with me, my email address is here. I'm happy to help. I do not consider myself an expert, but I'm very happy to assist where I can. And then I will leave it from there. Thank you very much.
Thank you so much, Dr. Keller. Very much appreciated. I will respond to the comments that both of you made about PHMDN. The new name of the organization is HealthWise, and they are the shared decision-making vendor quoted in Dr. Friedberg's study that now has the capacity to embed shared decision-making tools in EMRs. And we are working with EMR vendors to do this as part of our VIVID work. I also am going to just make a little outreach to somebody that had inquired about interest in the role of the health coach. Prior to the webinar, we had asked you to write in if you had any particular questions. This was addressed somewhat already in the presentation, but if you still have further questions, the person who asked that, please go ahead and feel free to write more questions about that topic. Otherwise, I'm going to go on now to other questions that we do have. The first one is directly addressed to Dr. Friedberg, and the question is, can you please explain the decision aid in more detail, specifically who creates this aid? Are they different for every patient, or are they specific to disease states and procedures?
Yeah, that's a great question. And I think Dr. Keller's presentation touched on some of this, so I'll give my take on it, but he may also want to expand on it. The decision aids, they vary quite a bit in exactly how they're put together, depending on the vendor that produces the decision aid. They can certainly be a physical booklet or some kind of electronic medium like a DVD, a recording, or something that's streamed through the internet that a patient can watch. And there's some, I think, some effort underway to have these be a part of patient portals to their electronic records. So this would be something that would actually be deliverable through a patient portal to make it more convenient for both the provider who orders the decision aid as well as the patient who is able to watch it. They are specific to the decision in general that is being considered. So, for example, for a man who's in his 50s and is considering whether to get a PSA screening test, there would be a decision aid specifically about the statistics, the science of what we know about the effects of having PSA screening, and also that decision aid would include some examples, in most cases, at least for the Foundation for Informed Decision Making decision aids, included examples of patients who would almost give a testimonial on both sides of the equation, both those who had the test and those who hadn't, to give patients a balanced presentation of how different decisions might occur. And of course, it'd be a totally different decision aid for something like mammography, a totally different decision aid for colorectal cancer screening, and a very different kind of decision aid for something like whether or not to have an orthopedic elective procedure. I don't know if Dr. Keller has anything to add to that.
I don't think I do. I think one of the things is you know, what these physically look like as well too, and you know, there's so many different topics, and but there's so many different ways to deliver this. You know, hard copies, DVDs, CDs, and then online, and how you integrate that into your practice is always a challenge, especially when you try to make it trackable. But there's a lot of ways to skin that cat, and so we're trying to find the best way to do it for each of the different areas we're working on too. So
just one thing to add to the discussion of just how many of these there are. I think it's important, and this is something we saw in our evaluation that I didn't touch on. Don't try to boil the ocean. It's too hard, I think, initially for an organization to, let's say, subscribe to the entire library of decision aids for all possible medical decisions, and then try to get those out to patients. That is a really tall order. It's probably a better approach to really focus in on one or two decisions and work through the kinks in the process in your own organization before moving on to other kinds of decision aids.
Wonderful. Thank you so much. The next question is, and it's not for either one of you, so it's not for one of you in particular. How did you deal with EMR or system barrier? Oh, it's actually, excuse me, it's for Dr. Keller. How did you deal with EMR or system barriers at Mercy?
Besides crying and gnashing our teeth, we were forced to do a duplicate process. We wanted it to be trackable in the EHR, which it really was not in our systems, and not to badmouth any one system, because I think everybody has found this to some degree, but we would document essentially under an ICD-9 counseling code that a decision aid was made so that we could see it on a problem list. But for the actual tracking, we had a separate process, initially using paper and then using some other software that allowed us to see which decision aids were given out, when we got the follow-up information on the patient, when they were referred as appropriate, what follow-up decisions they made, and so forth. And we could not find a way to fully integrate it in our EHR. So.
Okay. Here is another general question. What do you recommend providers do to engage patients to participate in shared decision-making instead of relying on the provider for the decision? And in doing so, how do you recommend that they explain options clearly to these non-medically trained patients without dumbing down the information?
Well, I think that's where sorry, I don't mean to jump in, but if you don't mind, I think that's where the decision aid helps you present information in a way that is meaningful to the patient. And if they're developed appropriately, and the ones that I showed on that slide I think are, they can walk through a patient even with relatively low literacy skills, health-wise or otherwise, through how to understand the information to make a decision. I think as a physician or a provider, you want to engage the appropriate patient on an appropriate problem. And again, as Dr. Friedberg said, pick something that you think is going to be relevant to you and your patients and work on this in a few areas. We had our reasons, but I personally think the ones that have potential surgical options or large health implications like arthritis and joint replacements, PSA screening, colonoscopies, as well as the ones that are chronic medical conditions. Diabetes was one we utilized a lot and I found to be very useful. Chronic pain was another one that I utilized a lot. So I started with a handful of basic things, became familiar with the shared decision aid so I knew what was in there, and then introduced the concept to a patient as we have a number of decisions that will be coming forward on this. We want you to have the best information possible. Let's have you look through this, come back, we're going to review the information, what you think is appropriate, and we will go forward from there. It's not really a one-time thing, it's an introduction of the concept to the patient, which can be brief. You can hand it off to somebody else to give them the information and take it from there. and then getting them back as you would for a chronic problem to review what they understand and where you go. It's obviously not appropriate for something like an acute MI or things like that, but where you have a chronic condition like diabetes, osteoarthritis of the knee, chronic pain, where you have a number of tools and options available, introducing it to the patient and saying, okay, we're going to be dealing with this for a while, and we'd like you to be involved in making the best decision. I think you're going to find 80–90% of patients are going to be interested in that and happy to move forward that way.
Thank you. Let's see here. I had another question. Oh, yes. So you did touch a little bit upon some tools for helping to train PCPs, but can you talk a little bit more about any particular tools that would assist health systems in particular to train their PCPs to apply shared decision making?
Is this specifically for me or both Dr. Friedberg and I?
Either one of you. Yep, you can just feel free to jump in.
We used a couple of tools. One, again, was we had structures in place, part of which was through our quality committees doing education on a large scale as well as on smaller scales, doing some lunch and learns with groups of physicians to introduce the concepts. And then I think those physician champions did a lot of the legwork here, where if you have somebody in your group who's getting better outcomes or has patients who are more engaged and more pleased, and the staff is talking about this, then the other providers are going to come to you and ask questions, and you can go to them in smaller groups and provide some information. So it was both formal and informal. You know, and there's some very good resources out there. HealthWise really did help us a lot on developing this, but I think we used the ongoing educational meetings that we would have, as well as some of these informal tools to help us educate our providers.
And just to add to that, one thing we heard from the practices in the demonstration that had done some provider education was actually that a big part of it almost happened spontaneously, and it was the physicians and other clinicians using the decision aids themselves, not as patients but as providers, watching the DVDs, reading the booklets, because of course they wanted to make sure they agreed with the information in there. And as part of this evaluation, I viewed a lot of these decision aids just to make sure I understood what we were evaluating. And I'm also a general internist. I don't practice quite as much as Dr. Keller, but I'd be dishonest if I were to say that I knew everything in those decision aids. They really are pretty tremendous, and they're almost like a very frequently updated, very well and clearly communicated review article on the decision in question. I think once you sort of see the materials, that's a big part of it for providers, because then they can sort of imagine, I think, pretty clearly how these can be useful in subsequent conversations with patients.
Yeah, and I would say, I didn't directly use this example, but I had a lady who really had no more than a second-grade education, diagnosed with diabetes, hadn't seen a doctor in over 40 years, and I can tell you that the ability for her to view that DVD and walk through what diabetes was and the simple steps she could take and what the options were was invaluable. And I don't like to use anecdotes too much, but I think it again showed another venue where this information can just be of so much value to the patient and so much value to the physician and provider as well. So.
Thank you both very much. Some great questions and some great answers. And I'll just add that we will be adding the resources that Dr. Keller mentioned into our VBID toolkit, which can be found on our member website, where you'll also find other great shared decision-making tools. So that's in the VBID section of our website, which is found under the employers in the top menu bar. So thank you both very much for your great presentations today. Very much appreciated. And thank you all for joining in and listening. We hope you have a wonderful day.